welcome back, and it gives me tremendous pleasure to introduce the next speaker. Bill Bahnfleth runs the best architectural engineering courses in the United States. He's actually getting architects and engineers to talk to one another. What are the, so I think it's the best building science program in the United States, and he also has the honor of being the past ASHRAE president. He also ran the ASHRAE Task Force, and he does like cats, so please welcome Bill.
Well, good morning, everyone. I hope we don't have a Phantom of the Opera moment here when the mask comes off. There's nothing to be afraid of. But it's an honor for me to be here and talk at this this great symposium. I never really expected an invite, and now here we are, and hopefully everything will go well. When I discussed maybe talking here someday with my friend Don Weeks, he said, well, you know, the speakers there have to be entertaining. So I'll do my best. So I'm a mechanical engineer by training. It's kind of a infectious disease epidemiology buff because I got into indoor air quality about 25 years ago, and the point of entry for me was a graduate student named Wally Kowalski who was really interested in preventing the next pandemic. And he also got me interested in ultraviolet germicidal irradiation, and kind of the rest is history. Stephanie did mention the anthrax incidents, bioterrorism in 2001, right after the Twin Towers. And that was also what got me into indoor air quality, because there was a huge amount of money released to figure out how to protect people from airborne microorganisms that happen to be engineered weapons. And so in one way, I feel kind of bad that we're doing this all over again and having to put this big effort in, because we answered all of the questions about how do we protect people from airborne microbial exposures 20 years ago, and then we just didn't do anything about it. So I hope that the difference now is that everyone's been affected, not just a few people in a few buildings, and that all the stuff you've been hearing for the last couple of years will actually start to infiltrate our standards and our practice. The outline of my talk is really the title, Buildings and Infection Control Before, During, and After COVID, with a little addendum put on. I've got a little case study of how the engineering controls that have been put in this room should be working to reduce risk. So I'll try to get through that. My former students like Brian Alt here know that I'm kind of a drinking from the fire hose kind of lecturer, but I'll try to leave time for questions. So with that, let's dive in. Infectious disease transmission on one slide. We could talk all day about all the interesting things about how diseases of various types are transmitted. I've listed them here. You know, our theory of disease is that microorganisms multiply in our body, and that's what disease is, and also that we get sick because we receive a sufficient dose in some susceptible location of whatever the microorganism is. So it might be the nose, might be the respiratory tract, it might be on the skin. All of these things affect what the dose needs to be. So this then becomes something that engineers are comfortable with. We're going to try to control an exposure to something that can cause a certain type of disease. And there are many pathways. Inhalation and droplet are what we're going to focus on here, things in the air that we inhale, because this is a talk about COVID. But touching of various types, sexual and otherwise, can transmit disease. Contaminated food and water ingestion can, and so can exposure to contaminated bodily fluids and tissue. So we're going to talk about mainly inhalation route and the current concern about COVID. So Joe asked me to talk about before COVID, so I start with Hippocrates in the 4th century BC, if that's going back far enough. And basically, what I want to point out here is simply that even way back then, the people who were starting to look at hygiene, whether it was occupational hygiene or buildings, recognized that something in the air we breathe was probably associated with disease transmission, and therefore we should be concerned about it. This was before anybody knew about disease, germ theory, or probably miasma hadn't even been invented yet, but they knew that there was something there that we ought to control. If we fast forward quite a bit, don't get whiplash here, going to the late 19th and early 20th century, we can find some people out there who, for practical reasons, were really concerned about how buildings might affect people's health. Florence Nightingale deserves a lot more notoriety than she gets. Observationally, she noted that you could reduce infections in a hospital if you gave people more fresh air, and actually if you gave them more light, and if you kept the beds farther apart. And so we had someone like that doing the right things over 100 years ago. John Billings was a physician in the U.S. associated with the health service, and he was the first, I think, to recommend 14 liters per second per person, or 30 CFM per person of outdoor air as a number that would be effective for reducing disease. And this was such a large number that it was hard to get it through natural ventilation, and it led him, this doctor, to write a book on ventilation and heating in 1893, which is kind of a classic, and you can actually still get this from Amazon if you want to get the Kindle version for your reader. Fluga's another important one. He was another hygienist, bacteriologist, and was one of those who pointed out the importance of airborne transmission, and he agreed with Billings about the ventilation rates. So there hasn't really been a steady historical progression where we make buildings safer and safer over time. There's actually been kind of a back and forth between, well, what do we really want to do with ventilation? The figure on the left here comes from a great ASHRAE Centennial article written for the journal. It shows that ventilation rates have gone from 4 CFM per person in the 1830s to 30 when Billings started to have some impact. And actually in 1914, before the flu pandemic of 1918, ASHVE, which is one of ASHRAE's predecessors, was recommending 30 CFM per person. There were 22 state codes, including Massachusetts, that were at that number. And then Yaglu came along, who I think was from MIT, if I'm getting that right. And he said, no, we should ventilate buildings for odors. That's enough. And so that got us back down to about 10 CFM per person. And we've kind of fluctuated between 10 and 20 and 5 ever since then. The last time we were at 5 didn't last very long. That was an energy crisis-induced number, and it was probably helpful in creating sick building syndrome. So that only lasted about one version of ASHRAE standard 90.1 or 62.1. On the right, we see the kind of data that's been used to justify our current ventilation rates. 80% not dissatisfied is about 7.5 liters per second, or 16 CFM per person, and that's kind of where we are today. And if you open up almost any indoor air quality standard around the world, that's what you see, that the definition of what's acceptable is no known contaminants at harmful concentrations, so safety from things like VOCs and particulate matter and some of the others, not pathogens. And most of the people who are in the space are okay with the level of odors. and we've found out that that's really not good enough. Those standards say a little bit about filtration, but less than you might think. If you read standard 62.1 carefully, there are a lot of buildings that don't require any filtration of recirculated air. You need to have it if you've got wetted surfaces. So what are the filters doing? They're protecting the cooling coil from being fouled by large particles. And we know that these MERV 6 and 8 filters that we use in our buildings are pretty good at that, but they really don't do much about stopping respiratory aerosols. The figure on the right shows the distribution of particle sizes emitted by someone who's on the bottom speaking or on the top coughing. The spectrum's about the same. The number of particles produced differs, but I've overlaid on that distribution the 3 ranges within which MERV-rated filters are tested. And we see that in ranges 1 and 2, which you can compare with the filter curves on the left, we have not very good efficiency. And so these minimum filters that we have currently are not really all that helpful. So prior to the pandemic, risk management really didn't address engineering controls, the things we can do with HVAC systems. It focused on other sorts of controls. Get vaccinations, which is always a great idea if they're available. Stay home if you're sick. That's a good one, or if you know you're sick. That got to be a problem during COVID because people could be infected and not know it for so long. One of the main things that makes it a bad disease. Cough into your sleeve. Everyone learn their proper coughing technique. Wash your hands frequently. Keep surfaces clean. I have a souvenir bottle of hand sanitizer I got during the last big influenza scare. It was down about 3 centimeters or 3 millimeters before I threw it away. So quantifying the risk of transmission when it's airborne aerosol exposure is really quite difficult. The process is kind of illustrated in this figure. You have someone who's generating an infectious aerosol. How many particles did we produce? What size are the particles? And very importantly, where are the pathogens in the particles? Because we don't have, we know, uniform distribution of viruses or bacteria in the particles. They tend to segregate towards the smaller end. And we have super emitters and those who don't emit very much, so that's got a lot of complexity to it. Then there's the transport phase. How do the particles move through the air, and how do they get to people who are receptors or susceptible individuals? And that's complex because if I'm standing up here, I'm mainly getting the average in the air that's being recirculated through the HVAC. But if you're sitting next to someone who's infected, and they're a source, there's a much higher concentration there. So the idea of one risk number for this space is difficult to come up with unless you have a model that hasn't been developed yet that can account for proximity to someone who's infected or not. And then finally there's the inhalation and deposition piece of it. How much air is someone inhaling? Where do the particles go? And on and on. So this is difficult. So we've done what engineers usually do and make it really, really simple. The Wells-Riley model jumps over how many particles are emitted and how many does it take to cause an infection, and combines them into one number called infectious quanta. So an infectious quantum is by definition an amount that will infect 63% of people who are exposed to it, and you determine what that is by analyzing the results from an outbreak. So it's not a number that you can really get by going forward. Now this is maybe the only significant equation in this talk. P is the probability of infection, and the important stuff is what I've colored there. I times Q, that's how much stuff is being put into the air, the number of infectors and the rate at which they're emitting infectious quanta. PT in the blue is the pulmonary ventilation rate, how much air you're inhaling multiplied by the amount of time. So that's the dose you receive because of the amount of air you inhale. And on the bottom in green, because green is a good color, is the uncontaminated air that we're using to dilute the source. And so this becomes an equation we can use for design by changing the value of Q somehow to get the P that we want to have, the probability. And we'll just discuss it at that level, but I will come back to this a little bit later on as well. And we have quanta production rates for lots of diseases. The original work by Riley, done in the 1970s, looked at measles, and that's a very airborne disease, 570 to 5,600. And we've got others that are, the quanta production rates are very small, like rhinovirus, 1 to 10, and influenza's been studied quite a bit. We also have now quanta for SARS-CoV-2, although this was the original strain. So a number of researchers, Buonanno et al., Lydia Marasco was involved in this, looked at data from a number of outbreaks and tried to come up with quantum numbers for a number of different activities. As I said before, whether you're breathing or speaking or singing or yelling affects the number of particles that are produced, so the quantum production rate varies with the activity. And if you go from the blue curve to the orange to the gray to the gold, you see there's a couple of orders of magnitude at any given percentile of occurrence, the probability of occurrence. But if we look at these data and the spread of their estimates from the lowest percentile of occurrence to the highest, there's 3 orders of magnitude. So all of that to say that we don't know these things very certainly, and when they're used in estimating risk, tend to pick something like the 95th percentile because that's conservative. Before the pandemic, we knew all of the tools that we needed to reduce risk. So ASHRAE published a airborne infectious diseases position document in 2009 for the first time, and it said all the things that we've had to say again during COVID. Diseases are transmitted through the air, HVAC systems can affect transmission, and we can control exposure with ventilation, airflow, pressure differentials, local exhaust, filtration, and UVGI, and that's pretty much it. So I could have given you the advice in this talk 10 years ago before anybody knew what COVID was. And so now we're in the present and during COVID. What are some of the things that come to mind as lessons I've learned after 2.5 years of chairing the ASHRAE Task Force and pursuing my own related research? As was noted this morning, we can make people safer, not safe. HVAC is one layer in risk mitigation. It doesn't have to do everything, and that's good because it can't do everything. The available controls haven't changed. We can dilute or displace with ventilation and air movement. We can capture aerosol particles with filtration, and we can inactivate them with UV. I'll talk about all of these things more in a little bit. Something really important is the idea of equivalent outdoor air. I think before the pandemic, we were kind of thinking about ventilation as one thing that was all by itself, and we have to put a filter in the building, and well, maybe we can add UV. Rarely did we think about how do we combine those in a rational way to achieve an outcome, and that, I think, is a really important change. And of course, and somewhat to my dismay on certain levels, the return of CO2 as an IAQ metric. I've been trying to put a stake through the heart of CO2-based demand control ventilation for years, and now everybody, including me, has a CO2 monitor that they carry around with them, and we're giving meaning to these numbers again that maybe they don't have, and I'll say more about that too. So there have been many case studies published during the pandemic, and we've learned a lot from them. Go way back to the beginning, the Guangzhou restaurant that was analyzed extensively, and this turned out, I think, to be a case of ventilation being really way too low. It was maybe one liter per second per person or something like that. There was no mechanical ventilation in this space, but also the infections were distributed as a result of the airflow patterns. Even though you would call this a mixed kind of space, it had a number of units that created closed recirculation cells, and all 9 of the infections were at one end where the infected person was located, over there on the red end in the right figure. We've seen evidence of airborne transmission in large spaces that you would think would be pretty well mixed up and ventilated. The one on the left is from a church in Australia, and unfortunately the infected person was the musician who was singing, so they were emitting at the highest possible rate, and you can see that there are 2 groups that got infected, some of them quite far from where that person was located in the loft. And on the right-hand side, here again is kind of an overhead mixing type of system. These are VRF cassettes in a restaurant, and there was one infected person, B there in the upper right, and there were 3 infections in that incident. The person who was dining with them, who was just kind of toast by definition because they were sitting right across the table from an infected person. But look at the other 2, A and C. So they're 6 or 7 meters away, close to 20 feet away. And then how would infectious material get from point B to point A, to reverse the usual direction? Look at how the airflow patterns from the 2 cassettes interact. There was a 1 meter per second velocity along that trajectory from one to the other, and they used cell phone records to show that one of these people was only in the restaurant for 5 minutes with the infected person, the other one was there for 20 minutes. So airflow is important, we learned. We also learned that unintentional airflow patterns in buildings can contribute to infections, which we also saw in the original SARS outbreak. A lot of this stuff was found in Hong Kong when the original SARS outbreak happened. So it's common I think in tall, multi-family buildings in that part of the world to have traps that get dried out. And then we know that SARS-2 and the original SARS can be excreted in feces. There's my potty moment for the talk. And that gets into the stack and can re-enter due to stack effect. And similar thing on the right. These are natural ventilation shafts in an apartment complex in Seoul, South Korea. They connect to the bathrooms and they have no backdraft dampers. So naturally ventilated. So at any given time, air can be flowing into or out of any unit from another one, and there was a cluster there as well. So we learned that sort of thing. The evidence on forced ventilation mechanical systems, less clear, but there's a case study from the Netherlands that I have always thought was really fascinating. It tells us something about what happens when we put our priority first on energy savings. So here's a facility with 7 wards, and of the 7 wards, there were no infections in 6 of them. In one of them, 81% of the residents were infected, and 50% of the healthcare workers. The healthcare workers were assigned to that ward. They didn't go to the other one, so there was not really cross-contamination going on. The residents would get out and see each other, but they had private rooms. So what's the difference between the other 6 wards and this one? This one had gotten an energy retrofit to upgrade it. So they put in CO2-based demand-controlled ventilation, and you get no ventilation unless the CO2 concentration where the sensor is above 1,000 ppm. So sometime the building would be in complete recirculation, and they had the kinds of filters we normally find in buildings, just dust filters. So to me, that's a pretty significant bit of evidence. Now, why haven't we seen a lot of that in other buildings with VAV systems, for example? We have a lot of multi-zone systems, and the likelihood of someone being infected in every space is pretty small. So if I have someone in a space that's 5% of the volume served by a system, and that goes into the return, it's diluted in all of that other volume. So I think we need to look carefully at some of these things before we can conclude that we can't transmit disease through ventilation shafts or through HVAC systems. And this brings me to another thing that I learned during the pandemic, which I really hang my hat on today, the precautionary principle. One way of saying it is one should take reasonable measures to avoid threats that are serious and plausible. What did WHO do when it was suggested that there was some case studies that showed that COVID might be airborne transmission? They said, well, we need RCTs. We need to do more research until we're really sure. What an engineer would do is, if I'm wrong and don't do anything, that would be bad. If I'm going to protect myself and I didn't need to, well, I spent a little money that maybe I didn't need to, but maybe I made the air quality in the building better too. So it's kind of a no regrets thing. But we really need to think in terms of protecting ourselves even against future ills, not just COVID, that might be of a similar nature, which is why I think we need to do something about our standards. I mentioned before the issue of engineering controls being just one layer. This is something else that we relearned during the pandemic. The NIOSH hierarchy of controls is not new on the left. This ranks different kinds of things you can do to prevent harm from a hazard. It applies to chemical hazards, all sorts of things, but we can apply it to infectious diseases too, and obviously getting rid of the source is always the best thing. Substitution has come to be interpreted as like do things outside instead of inside if you can. So we could even do that, substitute a venue. Engineering controls are, once we can't prevent the presence of infectious aerosol in a building, we can do things to lower the concentration. Administrative controls are rules and regulations, and PPE at the bottom is least effective. Now this is by effectiveness. Why is PPE at the bottom? Because this is where most people's masks are, if they have one at all, right? So you have to wear a mask for it to work, and you have to wear it properly, and it has to be a good mask. So masks are actually great, except that it's probably the thing that people like to think about least. Related to this in risk management is the idea of Swiss cheese, that no given intervention is perfect and they have different susceptibility. So the best thing to do is to stack up a lot of pieces of cheese with different holes in them. And I like this analogy because I really like cheese, but it's a good one. And it wasn't invented for the pandemic again. This is standard risk management that you can find if you go searching for it. So what's the difference between masks and ventilation? This is some work that was done at the University of Wisconsin where they tested masks for their particulate removal, for exposure reduction, and they tested different air change rates. And you can see that if we have mask efficiencies on the left that are getting up towards even 50%, we're getting close to an order of magnitude reduction in risk of infection, assessed by the Wells-Riley model, I should point out. And if we look at the increased ventilation scenarios on the right, we go from 1 air change to 5 air changes, and we cut the risk in half. So it takes a lot of outdoor air to have the same effect as wearing a good mask, and we can say this about other protections as well. Vaccination. Vaccination is good. This is some data from last year, but what it shows us at the top is infection rates and hospitalizations that result from COVID-19. The left block is the entire population, 267 per million at the time. The rate amongst the unvaccinated was 538 per million, and amongst the vaccinated, 21 per million. So people who were vaccinated were having hospitalization at a rate that was comparable or better to a typical influenza year. So again, there's tons of data about why we should be vaccinating, but that's not something that we have scope to get into today. So So let's get back to the engineering controls now after kind of laying the foundation. How much ventilation should we have? And you've seen the basic approach to determining what a ventilation rate should be. So we can do that, but there are other ways to approach it too. The World Health Organization, after a long time of not really paying much attention to it, came out with ventilation guidelines, and they recommend 10 liters per second per person, which is about 21 CFM per person for non-healthcare applications. And that was based on some work by Hugo Lee in Hong Kong that suggests that if you have that amount of dilution, that the background, the mixed concentration, is getting down pretty close to what it would be if you were outdoors. And so that was the rationale for that one. Harvard School of Public Health, bless their heart, introduced air changes into non-healthcare buildings as a way of measuring ventilation. And this is really kind of a problem that I'll dig into a little bit. They recommended that should be 4 to 6 air changes per hour for schools as being reasonable. And if you dig around and you ask Joe Allen, did you do a risk assessment to come up with that? He says, no, I looked at the ASHRAE standard 170, and those were the kind of air change rates that you were getting for patient rooms and the lower level of rooms where infection control was a priority. And you can also develop custom rates because there are a number of calculators around that will allow you to put in your own factors. And this is a very difficult problem because you have to check off a lot of boxes. What do I think is acceptable risk? Who's in the space? How long are they going to be there? What are they doing? So the idea that we can come up with a number that works well in all situations is kind of a fallacy, and that's why our ASHRAE task force actually didn't do that, and I've been taking flack for it ever since as the chair. So a little more about air changes and actual flow rates. If we look at the actual ventilation flow rate in the space, and we know what the source strength is, how much of the contaminant does someone produce, we can calculate how much that's going to be diluted. And so on the left, we see concentration dropping as the flow rate in, let's say, CFM per person goes up. Notice here also, though, it's diminishing returns. If we double the ventilation rate, we half what the concentration was at the previous one. So if I started at a concentration of 1 and a ventilation rate of 1, and I go to 2, now I'm at 50% of what I started out with. If I double it again, I have to go from 2 to 4, but now I'm at 25%. So the return on more and more outdoor air gets worse and worse. So what about air changes per hour? All they tell us is how quickly we get to the steady state. So the figure on the right shows that the higher the air change rate, 1, 2, 5, the faster I reach the maximum concentration that I'm going to have. And you only know what that concentration is when you convert that number back into CFM and do the other calculation. So this is a problem, and sometimes you can have conflicts between them. So let's look at an ASHRAE standard 62.1 office space with default density. So 5 CFM per person and 0.06 CFM per square foot. The typical density in the standards is supposed to be 5 persons per 100 square feet. So if we had 1,000 square foot office space, we'd need 85 CFM, and that works out to 17 CFM per person, or 8 liters per second per person. And if you're looking at the WHO number, say, well, I could do better, but it's not bad. Maybe I can get there with a little extra work. But suppose we've got a typical 9-foot ceiling, and I convert this to an air change rate. It's less than half an air change. Oh my, my hair is on fire because I'm in a really dangerous space. So how do you reconcile these? And I think my answer is we stop using air changes and focus on a better way of doing it. All right, so one more sad note about this. I hate to always be the bearer of bad news, but all the the systematic reviews on ventilation and infection control have come up kind of like this one that was done by Hugo Lee et al. In 2007 and published in the Indoor Air Journal. We got plenty of evidence that more ventilation reduces infection risk. We just don't know how to specify a minimum rate based on what we know. So our ventilation rates for infection control may be a lot more than we need because it's not possible to accurately come up with a number that we can put into a standard right now to say that's enough. So that's the issue of how much outdoor air. It's also important how it's distributed, and you saw that in some of the case studies that I went through briefly. So we have at least 3 different ways of doing ventilation that are out there. Overhead mixing, like in this space where we've got diffusers overhead that are creating big circulation zones. I can tell it's working because it was dumping on me when I was sitting over here during the first presentation. So that's supposed to create a uniform concentration. Stratified, we put air in low and we're cooling and we push contaminants up. And that works great for body odors, human thermal plumes, things that can be entrained into the human thermal plume. And then personal ventilation, which has been pushed for a long time by Arsen Melikov at Technical University of Denmark and others, is putting the air where the people are. So if you have a configuration where people are going to be in the same place for a long time, like here, you could give everybody a little diffuser, give them a little fresh air, and you wouldn't have to provide so much for the space. The problem is that all of these can fail in implementation, and we've seen that with all of them. So we already talked about the Guangzhou restaurant. That's mixed, but there was a big outbreak there, and we see how air diffusion in a restaurant created risk where there might not have otherwise been any. That's on the left. In the middle is some interesting work that was done a few years ago about healthcare ventilation with stratified displacement ventilation systems. And what they found was that because this infectious material is being exhaled, it gets out of the human thermal plume and can stratify in the air in a space under some conditions. And you can see the visualization there. It actually happens that you get a cloud there in the breathing zone that's going to create higher exposure, and you see some modeling below that shows the same thing. So these authors actually recommended not using displacement in healthcare facilities because it could increase risk, and yet we often think of it as the most IAQ positive kind of ventilation that we can have. And on the right, the obvious thing is that personalized ventilation can be foiled by a lot of people moving around, which tends to mix up a space. And all the CFD analysis that people do often is done for lack of resources with mannequins that just sit there. And so you get different results from a space where nobody ever moves and one where you actually have a normal amount of movement. One more note here. There's a study that's just come out. It's still a preprint, so with that caveat, it was done in Italy in schools, and they looked at over 10,000 classrooms. And this was because a program was funded there to put mechanical ventilation into classrooms. And so out of those 10,000 plus, 316 were retrofitted with mechanical ventilation, and they compared the infection rates between mechanical and natural ventilation and found that the rates were 80% lower in the mechanically ventilated classrooms when they had 10 to 14 liters per second per person, and they also found that there was about a 12 to 15% reduction of risk per unit of ventilation. So now let's move on to the equivalent outdoor air idea, and here we bring Wells-Riley back again. We can replace the Q in the denominator there, which we originally conceptualized as just being outdoor air, with air that's been cleaned or purified of infectious material by any means. So we could take an air filter and look at the rate of particulate removal and express that as an equivalent amount of outdoor air. We can take a UV system like we have in the space and come up with an equivalent airflow for that. Now when we put everything on the same basis, then we can look at what's the best way to add these different things together to get the effect. It's a little bit like in the energy world, having to put everything in the same units before you do calculations, you know, barrels of oil and gallons of gas and tons of coal and kilowatt hours of electricity. Just the same idea. And so if we determine what the total rate should be, at least for pathogens, then we can look at a variety of different solutions. So, you know, simple example, if a fan has 500 CFM of flow and we have an 85% efficient filter in it, then that's like having 425 CFM of outdoor air from the point of view of those particles. Filter efficiencies need to be higher, as I mentioned before. How much higher? We've recommended MERV 13, maybe because 13 is a number that makes everybody uncomfortable. We could have said 14, but we picked 13. But if you look at the spec for MERV 13 filters, you see that compared to a MERV 8, which is in 62.1 now, where there's no minimum required for 0.3 to 1 micron particles, it requires 50, and where the minimum for 1 to 3 was 20%, it's 85%. So this makes a big difference. And one of the things that the ASHRAE Task Force did was come up with this table that looked at respiratory droplet size distributions and where the viral load was in them, mostly looking at influenza, and then came up with efficiencies that could be used for estimating performance. All this stuff is on the ashrae.org/COVID-19 webpage, if you're interested in going there and digging around. So we can do some calculations this way. A persuasive study, although it's an isolated one, was this modeling done by Paramazimi, who was a postdoc eventually at Harvard School of Public Health, but he started as a PhD student at Illinois Institute of Technology. And he worked with Brett Stevens, who's a great IAQ researcher. And they looked at an office building and compared risk of influenza infection with increased filter efficiency and minimum outdoor air or increased outdoor air. And the results are shown here in cost per air change per year. And what you see is that what they found was that relative risk on the vertical axis decreased steeply as you went from MERV 4 to MERV 13 filter, and got down to 65% reduction. And then after that, there was not much effect at higher filter efficiency. So you could pay for more efficient filters, but you weren't getting much impact from them. And ventilation is always much more expensive, the colored curves that show different locations. So filtration is good, and a lot of buildings can't have filters put in them for various reasons. You have once through outdoor air supply, so it doesn't help to put a filter in the outdoor air if it's just going to be exhausted. It's got to be recirculated, or maybe you can't upgrade the kind of equipment you have to the needed level. So standalone air cleaners are great. I've got them room by room in my house, so I can turn them on when I need them. All you really need is a good filter. If you're buying a commercial unit, why not get HEPA's? Because they give you the most clean air delivery for the buck, but you don't necessarily have to. Many of these have other magic technologies packaged with them that make them sometimes 10 times more expensive, but they don't really do anything better as long as you've got the right clean air delivery rate. UV, probably not necessary if you've already got a HEPA filter, but activated carbon usually comes with a lot of these filters, and that's good if you've got odors. You can see one of my air cleaners here in my basement on the left, and I pulled the filter out. You can see the black on the inside. That's the carbon layer. The air goes through from the outside. There's a little pre-filter layer, and then the HEPA. And that's my cat Marv sitting next to it for scale. Our cat sitter calls him Merv, and he weighs about 13 pounds. So this is a comparison between a HEPA and a MERV 13. Thank you very much. I'll be here all week. Remember to tip your servers. So these were a really good thing, but again, we discovered during the pandemic that we didn't know nearly enough about how to deploy them. So, well, you know, you could buy one for years and years. It was a good product, but we didn't know very much about where you should put them in a room and could they increase risk, and so there's a lot of interesting ongoing work about that. I've answered endless questions about, do filters remove biological aerosols from the air? Do they reduce risk? And then usually from people who've never seen those filter curves we were looking at, because they think that because you only test to 0.3 microns, that nothing below 0.3 microns gets through. And they also don't know that a lot of the particles that have viruses in them are a lot larger than 0.3 microns. So yes, but here's a study that was done in a healthcare facility in the UK, and they put in HEPA filter units that also had UV in them, and they did a pre-operation filter on, filter off, filter on, and what they found was that there was a lot of microbial load in the air, including SARS, before they turned it on. They couldn't detect anything after they ran the filter unit for a while. They turned it back on again, and the microbial load in the air returned, and they put it on again, and it disappeared again. So there's plenty of that kind of evidence, so don't let anybody tell you that filtration isn't potentially helpful. Here's some work that was done early in the pandemic by a big hotel chain that was concerned about their banquet facilities and lobbies and that sort of thing. So they commissioned some work, both modeling and experimental, that showed that portable air cleaners, if they were, say, put on a dining room table, could reduce risk significantly, not completely, but you can see in the table or the bar chart at the bottom, reduction in exposure is pretty good, and very good in some cases. Kind of depends on where the source and where the receptor is. And even do-it-yourself air cleaners can work. The Corsi-Rosenthal box, which you'll hear more about later today, has been a phenomenon. I'm standing next to one here on the dais, and what this proves is that moderate efficiency and high flow rate can be as good as high efficiency and moderate flow rate if you've got some ability to remove particles in the range that you're concerned with. And believe it or not, this was not invented during the pandemic. Well, the CR box was, but for wildfire smoke control, this had been discussed for years, and the EPA had already done some studies on them, just one filter on a box fan, and they had UL tested them and found that they weren't a fire hazard, and they found that they removed particles. So that is a possible solution. And here's some data that was taken at the University of California, Davis, where Corsi is the Dean of Engineering. I don't know if there's any connection there, but what you see is the CR boxes, which of course have big fans, were producing larger clean air delivery rates than the commercial HEPA filter units that they tested. That doesn't mean they're better. It just means that they could get a lot out of these inexpensive things. And if you look on the right, this is really important because it shows that by particle size, the clean air delivery rate with the MERV 13 filters is actually pretty good across the board and compares favorably with the HEPAs. Right, so then we have the other disinfection technologies. I'm going to talk about UV, but I want to just mention additive air cleaners that are basically adding oxidants to air. Bipolar ionization, hydrogen peroxide, photocatalytic oxidation, triethylene glycol. Anyone heard of that proposal? Anyone know what triethylene glycol is one of the main ingredients in?
Yeah.
Theatrical smoke. Theatrical smoke. So, but it's been studied as a disinfectant since the 1940s. The problem with all of these things is they really have not been vetted very well for either effectiveness or safety, and we don't have good standards for them. And it maybe goes beyond the precautionary principle to use them during the pandemic. In fact, maybe we should apply the precautionary principle to air cleaners that put stuff in the air that we're going to be exposed to that haven't been fully evaluated. So that's why they're not really on the list. And to the point of effectiveness, here's some data that was taken by a major HVAC manufacturer. You can see their name in the URL. These were typical pull-down tests where you have a chamber and you seed it with a microbial aerosol, and you do a test with the technology off, and you measure the concentration in the air over time because it's going to deposit and lose activity. And then you turn the technology on and do it again. The other thing I want to point out in the figure on the left, which shows the airborne concentration results, is that natural decay curve, the red one, is practically the same as one of the cases that was studied. And these tests always tell you at the end of the day, well, you know, after 3 hours, they're 99.9% was removed. And of course, if you waited long enough and didn't have the technology, 99.9% would be removed too. So you got to do some calculations at the end. There you see the natural decay was 70%, and we've got some that are only 80%. When we turn that into clean air delivery rates, sometimes these aren't very impressive. And then they also tested surface disinfection, and you can see the comparison between natural decay and the unit in the figure on the right, and there's no difference. So that's why we should be using germicidal UV more, because it's a technology that's been around for over a century and has been applied over and over again. It was used for operating room disinfection in 1936. It was first tested in schools for childhood airborne disease transmission prevention starting in the late 1930s. It's been approved since the 1990s at least for tuberculosis control by the CDC. And mainly this is done with technology that is little different from a fluorescent lamp. Low pressure mercury vapor lamps are basically fluorescent lamp technology. The only difference is that you have a different tube that allows the 254 nanometer UVC that's produced to be emitted instead of putting a phosphor on a glass tube so that it's absorbed and it re-emits as visible light. How does it work? Photons of the right energy will break bonds in DNA or RNA, adenine, thymine, cytosine, guanine. So it's the adenine-thymine bond in DNA that gets broken. It's adenine uracil, I think, in RNA. But so anyway, we do enough of that damage and the microorganism can't reproduce. Viruses aren't necessarily alive, so we can't say we killed them, but we have made them sterile in a sense. So that technology is well established. That's what we've got in the room here. There's been a lot of development. I think LEDs will eventually replace the mercury vapor sources for a variety of reasons, and also things like krypton chloride lamps are coming out. And what's important about those is that they have some safety implications. 254 is pretty irritating to eyes and skin, so that's why we have to keep it above our heads here. If we could get down to 220, some of the research on that shows that we might be able to actually expose the whole space and do surfaces in the air between people in real time, or at least we would have much safer upper room systems. So how well do these work? It's kind of hard to show it for these systems because it's complicated interactions with the dimensions of the space and with airflows, and often they're expressed as air changes per hour. 10 to 100 is possible. 10 is a pretty conservative number. 100 and better than 100 has been measured, and it's hard to beat that with any of the other technologies we've been looking at. Microbial characteristics influence how well UV works. So there's a microbial resistance coefficient we call K. And some things like anthrax have a really small one. Small one means they don't respond much to UV irradiation. Other ones are much larger. Coronaviruses, influenza, measles, a lot of the viruses we're concerned about are actually very susceptible to UVC. The equation here shows how survival goes, and so it's a function not only of the microbial susceptibility, but also the dose. So I is the intensity, if you will, of the radiation, and T is the time of exposure. And you can see in the figure that a coronavirus over 2 seconds with a 500 microwatt per square centimeter dose goes down to maybe 2 logs or more of reduction, while anthrax says, what was that? And is hardly affected at all. But spores are big and you can filter them. So this is where we get into looking at different ways of dealing with different kinds of contaminants. So upper room is one of the applications. That's what we've got here. And you try to create a disinfection zone that room air circulates through due to human thermal plumes, due to the HVAC system's operation. And in some cases, they even put ceiling fans in to make sure that things get mixed up well. And so we want to keep that above the heads and have below the acceptable daily dose down in the occupied zone. As Bill Palmer carefully went around with his radiometer and checked the whole room out on Saturday, and again spot checked it today to make sure that it was functioning the way it's supposed to. So that works very well. That's the most effective way to use UV, maybe the most expensive too. We've also put it in air handling units for a long time. The problem with air handling unit installations, there's several. One is you can't get any more clean air than the system is moving. So what's a VAV system at full blast do? 6, 7 air changes per hour. And you've got your high efficiency filter in series with it. So if you have a filter that's doing 85% of the work, you can put in UV and you do like 95% of the last 15%. So the incremental benefit's not so large. But you can also keep coils free of slime, and that actually can save energy in systems. And we use it to disinfect spaces when they're not occupied as well. So I mentioned the 1937 installations. Here's the Germantown Friends School, and there's an upper room fixture you can see there in the center of the room. And some of the data from that study over on the right, they looked at a number of different diseases. This is weekly measles cases, and so they had control classrooms with no treatment and some that did, and you can see that there are huge transmission rates, new cases in the unirradiated rooms, and never got above 5% in the ones that were irradiated. Now, these studies were replicated in different cities, and they didn't get such good results. And this brings up another important point. At the Friends School, the kids tended to be picked up from school and go home and not mingle too much. Some of the other places they did it, they were on school buses, and in others, it was common for them to play in the street in big groups. And that's the point, is that the protection has to be end-to-end. So you can have perfect protection here, but if you go somewhere else after the meeting and expose yourself to a lot of risk, then all the work that was done here doesn't help you that much. On the new technologies, just a couple of points. On the left, we have some data that shows getting 3 logs of reduction of SARS-CoV-2 using different wavelengths. What does 3 logs mean? 1 log would be we reduced at 90%, 99%, 99.9%. So that's kind of the gold standard for disinfection. What we see is that all of these wavelengths from 222 to 282 work pretty well, but they take a different amount of time. It takes a different dose to get there, and the 222 worked quite well in this case. Also been tested experimentally in chambers and found to work pretty well also. So that's coming, not really fully in the marketplace yet, but it's coming along. And let me say just a word about CO2 measurement. I think it's useful with caveats. It's great to walk around with a CO2 sensor and know if you're in a room that's reasonably well ventilated or in one that's poorly ventilated, or maybe when it's time to open a window. Putting too much faith in any given number, if I've got 800 ppm, then I am safe. This is a problem because they're often spot numbers. Remember, we can have transients. So if I measured 600 ppm in here right at the beginning of the day, now we're at 1,200, but if I drew a conclusion based on that number, I would think we were better ventilated than we were. And the same can happen when concentrations are going down. The data here on the left is interesting. This is from my travel day. So there are 3 peaks there. Well, ignore the one on the far left, because that was at home, and I'm not sure what was going on. You can see what it really was at home, more like 800. And so the first peak, and many would know this, was when I boarded the airplane before they turned on the onboard HVAC. Got up to over 1,800, not too bad, but not great, and then it dropped down to 1,000 when we were flying. In the airport, didn't really see any increase. Philadelphia airport was well ventilated. Second peak, on the plane to Logan, and the same thing again. The third one is driving my rental car from the airport here. Fortunately, it was just me, so I don't think I posed any risk to myself, at least not in that sense. So I'm thinking to myself, 2,000 ppm, how did that happen? It turns out, why did they do this to us? I drive a Sienna van. The recirc is off unless I want it to be on. My Camry, I turn it on, and somebody wants to save energy, the recirc comes on automatically. So you have to decide to turn it off. So we can learn things. But this is complicated, and if you really want to learn more about it, read the ASHRAE position document on indoor carbon dioxide, which just came out, and you can go to the ASHRAE website and download it. It covers really soup to nuts on what carbon dioxide means indoors. And one more point here, don't neglect maintenance. I think we had a good example of that just with the recommissioning of the system. Who knew that the outdoor air dampers were closed? But anyone who's actually looked at real systems in the field knows there isn't anything. I tell my students, think of the dumbest thing that could ever happen in a system, and give me a week and I'll find you someone who did it or found it on a project. So maintenance is really important. We need to look at systems and make sure they're operating properly. The figure here, which is probably really hard to read, is from a General Accountability Office, GAO, that came out, the work was done before the pandemic, and what they did was look at schools and what were their maintenance needs. HVAC was the #1 item. 41% of school districts in the US with 50% or more of their HVAC systems that needed repair or replacement. So when we give people advice about what should we do during the pandemic, the first thing we say is make sure your system is working the way it's supposed to, and then we'll talk about what you might want to do to improve it. And of course, we have a lot of schools that are naturally ventilated. They have operable windows that don't operate for various reasons. Painted shut, security concern. We really need to actually look at buildings and not just think about them in our office. I mentioned the ASHRAE guidance. The core recommendations is the one-page summary of it, which I've shown here on the right, just as a graphic. Don't try to read that, you'll hurt your eyes. There's a section called Building Readiness, which kind of is the sort of thing that we did here. It's assessing a building and its systems, planning upgrades, and implementing them. And there are some tools there to help the user do that. And there's also a lot of facility-specific guidance for different kinds of facilities. Healthcare, which focused mostly on surge facilities. How do you make a room that isn't an AII into an airborne infection isolation room? Commercial schools, and residential, single and multifamily. I got COVID when I was at a conference in the Netherlands a month or two ago, and I came home, and my wife wasn't infected. I emailed her before. I said, wear your N95 to the airport and keep the windows in the car open. And I was testing positive for 15 days, and she didn't get it. And we did everything that we had recommended here about isolating and ventilating and using portable filters. So this stuff really does have some value, and you can find all of that at ashrae.org/COVID-19. The future in one slide. Things that I'd like to see, or that maybe some of them we will see. IAQ standards that include infection risk mitigation. That's a heavy lift with committees like 62.1 and 2, but we're talking to them about it, talking to the government about national model IAQ standards, if that would have some value to drive that effort. IAQ control that doesn't rely on outdoor air to do everything. That would be great, because we've already become well aware of the limitations. And along with that, using the alternatives to ventilation that we know work. Integrated IAQ design based on equivalent clean air delivery. We can take that concept and we could put it into the standards, which don't really address anything but ventilation very much right now, and that would, I think, be a big game changer as well. We need to target control of particulate matter, especially. I was going to say in particular, but that's kind of redundant. Why? Because viruses aside, exposure to fine PM is probably the #1 indoor air quality hazard. We talk a lot about VOCs and other things, but if you look at the health effects of PM around the world, that's really the thing we should be working on, I think, the hardest right now. Design for multiple operating modes. We don't want to, and won't be able to operate every building like it's a healthcare facility all the time, or like an airborne infection isolation room. But our standards all tell us how to design a building to operate when everything's okay. We're not having a wildfire, we don't have an infectious disease outbreak. We need to think ahead about what kind of affordable modifications we could put into design, preparations, if you will, so that when we need to operate at a higher level of protection, we can do it. Next generation demand control is something I think is critical, because we're never going to get better IAQ if we can't convince the people who are more concerned about decarbonization and energy use that we can do it without derailing their efforts. And I think different sensors maybe, and multiple contaminants, and more localized demand control, finding where people are in a building and giving them good IAQ and turning things down where you're just wasting energy would be really helpful. I talked to Real Estate Board of New York early in the pandemic, and one of the things they told me that stuck was, you know, we've got these office buildings in Manhattan that are 5% occupied, and they're using 95% of their full occupancy energy. You know, this does not speak well of our approach to conserving energy in buildings. So there's a huge opportunity here to have better air quality and to have buildings that use a lot less energy than they do. And why not win on both sides? And I think real-time disclosure of IAQ as well, dashboards, and Stephanie covered this very well in her talk, so I won't spend any more time on it, but visualizing IAQ somehow, making people aware of the quality of their environment has value. So now let's talk a little bit about this installation that we have here, and I think it'll still leave some time for questions. So we've got UV system, we've got Corsi Rosenthal boxes, and we have a few various CO2 sensors wandering around the space. And I tell you, Lou and I have been comparing notes, and we're doing pretty good here. We don't have really full occupancy for this space, but I'm seeing anything from 1,000 to 1,200 ppm here, and that's really pretty good. The acknowledgments have already been made, but let me make them again. I'm very grateful to everybody who got on board with this super idea and put all this stuff in place. Yeah, I've been to, this is maybe the 5th conference I've been to this summer, and all of the rest of them screwed it up to a greater or lesser extent. The indoor air conference in Kuopio, Finland was the best by far. They gave everybody self-tests for every day of the conference. They gave out masks. They repeatedly told people they really ought to use them. They said, you know, infection prevention is not just in the sessions, it's actually in this room we're in. And they were well-ventilated places. But this is the only one I've been to that's really walked the walk of putting in all of the things that we could do, and we show that it could be done pretty simply, and you'll see that it has a big effect. So this is really kind of a landmark, and I'm hoping actually that we can write a case study on this when we get a little more data on all of it. So the Westford Regency Ballroom that we're in, 120 by 58 by 13, so about 7,000 square feet and about 90,000 cubic feet. And there are 3 rooftop VAV air handling units that serve it. According to ASHRAE standard 62.1, if we assume that this is a well-functioning mixing ventilation system and it's a lecture classroom, which works out about right as far as the density. The default density is 65 people per 1,000 square feet, so that would give us 452. We're a little under that, but that's not far off from what I heard was the sign-up for the symposium. We should have 3,808 CFM of outdoor air. That gives us a ventilation rate of 8.4 CFM per person off the bat. That's not real close to 21 CFM per person, so we're pretty far under 10 liters per second per person. As an outdoor air change rate, it's 2.5. If we assume a 13-foot ceiling, and 3.8 if we have a 9-foot ceiling, and there's another problem with air change rates. You know, what air change rate do you want? You know, I'll tell you what the ceiling height is. Or if we don't like the ceiling height, we'll use the breathing zone volume. So if I take the 13-foot ceiling and do an estimated CO2 concentration, I get 17, 19 ppm for this space, and we're well under that, either because of inaccuracies in my data or because we're not up at that volume. So the team went out and did an assessment and tuning and filter upgrade for this system. As ASHRAE recommended, it was multidisciplinary. We had engineers, we had facilities people from the hotel, manufacturers got involved in this. So it was the right way to do it, and they answered questions like the ones you see here, making sure you know which rooftop unit serves which space and all of the other data. And then there was the filter upgrade during a second pre-conference visit, and also outdoor air measured at that point. So 6 existing MERV 8 filters were replaced with MERV 13. You can see that in process. Another one of those fun examples, the filters that were specified by the manufacturer didn't fit and had to be field modified. Lou called that origami, filter origami, so that they would fit, but I've seen filters that were folded up a lot more than that and stuffed into air handling units. So we've now got a good fit after they were fixed a little bit. Ventilation measurement was the interesting part, where they found that it was a hard 0. The damper was closed, as you can see, and it was necessary to use a little ingenuity and tape to make sure that it was open while we're occupied. Airflows were measured at 2 different fan settings, and they were significantly below 62.1 in both cases. We don't have supply airflow rates, but we estimated them typical ones. All right, so here's a summary at the high flow rate, which we took to be about CFM per square foot. So the outdoor air should be 3,800 by ASHRAE. Recirculated air, if we had 1 CFM per square foot, 12,000 CFM would be 8192. And then I took the recirculated air and those filter efficiency numbers for viruses from the ASHRAE Task Force data, and I calculated what the equivalent outdoor air would be for them. So that's what you see there. So MERV 8 with 8192 CFM of recirculation is like another 4,000 CFM of outdoor air, as much as we're actually bringing in. So that's another 8.9 CFM per person and another 2.7 air changes. Put in the MERV 13 and it almost doubles it again. We go from 4,000 to 7,000, and that's another 15 CFM per person and another 4.7 air changes. So if we add them together, with MERV 8s, we wind up with 17.3 CFM per person total equivalent ventilation and 5.2 air changes. which is getting up there to where we've been told we should be during the pandemic. With a MERV 13, we're well over at 24 CFM per person, which is more than 10 liters per second per person, and 7.2 equivalent air changes. But wait, the problem with VAV systems is that their performance is not constant across the operating range. So if you turn down the supply airflow, things will change. And I assumed that this was a system that complied with 62.1, and if we had a full room, we would still bring in the design outdoor air. So what that means is when you go to low supply airflow, the recirculation goes way down. So the recalculated recirculation at the minimum flow rate was only 992. So we're now getting a puny 1 to 2 CFM per person out of our filter upgrade. And at the end of the day, we've got only 9 or 10 CFM per person when we add together the outdoor air and the filtration. And we're not up to even 4 air changes per hour if we want to look at it that way. So this is important when you evaluate a system that doesn't function at the same flows all the time. You have to look at what is the worst case. And what this tells us is if you really want to be protected all the time in a space like this, you ought to do something else. And so we did something else. So the CR boxes that Lou put together turned out to have about 500 CFM of flow it was at their top speed, and there are 4 of them. I estimated the clean air delivery rate, since those are MERV 13 filters, at a total of 1780 or 3.8 CFM per person. It's about 1 air change. That's probably a little low for this room. If you were to buy air cleaners from AHAM, they would recommend 4 air changes per hour, and it's partly just to make sure you get good circulation in the room. It's also partly because AHAM represents home appliance manufacturers, and why have 1 air change when you can have 4? I don't know. So undersized, but we can calculate what the contribution would be. So in principle, we've shown how that's done. And then there's the UV, which is the 600-pound gorilla of room infection control. Bill Palmer put together these stands to do a temporary installation. We've got 4 fixtures. 3 of them are so-called open fixtures, so there's nothing blocking the lamp, which means you get really high output. You can do that because we have a high ceiling, and it puts the light up into the ceiling cavity. The other one, kind of for demonstration, is a typical louvered fixture. These are used in lower ceilinged rooms, and what they do is create a sharp beam as they're closer to the occupants, and we don't want to have leakage down to where they are. You can see in the lower image here the visible light that's put out by the lamps, and you can see how the fixture over here, the open one, is throwing a lot of light out up into the ceiling cavity. The one on the far right is the louvered fixture, and you can see on the wall how sharp the beam is coming out of that. So the sizing here was based on experiments that have been done for tuberculosis control, and 12 milliwatts per cubic meter of power in the open fixtures should get about 24 equivalent air changes, and that's being done with 15.5 watts of power input. The fixtures aren't cheap, but the energy use is pretty small. So that's what we've got, and this shows some of the kinds of calculations that can be done to design these systems. This isn't the final configuration that Bill came up with, but you can see where the sources were in this one. There are 2 here and 1 centered in the back, and we've added the range of UV fluence there. So we're looking at the plan view in the top figure, and the bottom one shows a section through the long dimension of the room here and how the high intensity is confined to the upper part of the room. All right, so what does all this stuff get us? I did a lot of calculations that I won't go through because there's no time and they would bore you to tears anyway, but I had fun because I'm an engineer and a spreadsheet jockey. So the first thing I looked at was what's the exposure reduction? So if we just look at equivalent outdoor air and how much should the exposure be reduced relative to the existing system with the dampers open and upgraded filters, and then add the CR boxes and then add the UV, we're getting about a 30% reduction with filter upgrades, and we more than double that by putting the UV in the room. So when we've got everything. The other thing I did, after having to leave the Joe's house early last night to produce these numbers, I want you to know I've suffered for this talk, was
Take it out tonight.
Believe me, I'm taking the bus. I pulled up one of the available risk calculators and ran some calculations, assuming 70% vaccinated, which is about where the U.S. is, fully vaccinated, 4 infectors in the space based on about a 1% incidence in the population. Typically, there are about 3 million people infected with COVID-19 right now, according to my sources. And I did a no-mask baseline, so nobody's wearing a mask. Okay, so if we take that baseline and everybody puts on, or half of the people put on an N95 and wear it properly, relative risk is 55%. So that's what would happen if we did nothing and just wore masks. Now, the second bullet here, what if we do the MERV 13 CR box upgrade? That gets us a 37% reduction in risk predicted. And when we add the UV to that, it's 63% reduction. So that's pretty good. I mean, relative risk is kind of what we live by these days because the exact risk is hard to know. But what if we have all of those things and 50% wearing N95 masks? We've reduced the risk by 92%. So this goes back to my original point that layers are so important, and some of these things that are inconveniences actually can help quite a bit. So final thoughts before you get to beat me up. The industry that we're in, and it's a very broad industry, needs to think about infection risk in indoor environments, apply the precautionary principle, and make sure that 100 years from now we're not doing this again with some new pathogen. Right before COVID happened, CDC had a big symposium, the 100th anniversary of the 1918 pandemic. Are we ready for the next one? Well, no. Risk assessment's imprecise, but I hope I've showed you that despite that, we know how to lower risk and to at least broadly quantify it, if not precisely, using a few simple tools that relate to building design and operation. We can't eliminate risk, so we shouldn't try to. But we also should recognize that by designing buildings better, we're making a contribution to this overall effort that has a lot of value. And I think I'll end with the comment that more and more outdoor air is not the best way to reduce risk. Both from the point of effectiveness, which we just saw, and also from the point of view of energy use. So we should be using more filtration and especially UV for infection control. To not do that, as someone once said in a presentation I attended, would be a stupid thing. So with that, I will end. And for Stephanie, Marv has a nice blep. Be happy to have some comments and questions.
Thank you very, very much, Bill. Please, questions? Anybody? Yell.
Can I go first? Since So could you make any comments on electret degradation and the filters? Like how long do they last? How long do these last? You know,
yeah, I mean, they're similar media, right? These are electrostatically charged. I only wore a mask for 2 2-3 days before I change them out. They're not that expensive. But there's so much controversy about electret media.
Right, exactly.
Right, so we've got the MERV A rating in 52.2 that tries to take that off and see what the filter will do. But there's a lot of controversy about how long it takes, and some actually believe that the dust cake that builds up on a filter to some extent compensates for the loss of electrostatic effect. I say jury is out, and I hope we look at it more, because nobody's really got a good answer. But we do know that there are cases where a certain operating environment can really cause a electret filter to degrade. And if you were putting in 1-inch charged MERV 13s at the beginning of the pandemic, if you didn't change them often enough, you might actually have a MERV 6 or 7 that was worse than the filter you had there to begin with.
So really, it's a controversy.
Important issue, but I can't give a definitive answer on it.
Okay. And I work with Brian, so I'll find you tonight, but I have one more quick question, maybe quick. UVC in residential settings in people's houses, what do you think?
Well, it has some value if you can do it in air handling units for keeping coils clean and for some amount of control. I worry about it from a safety point of view as long as we're using fixtures like this. I can almost touch my ceilings. I live in a house that was built in 1948. The ceiling's maybe 7.5 feet. Put a fixture on the wall there, like somebody's getting up to put the star on the Christmas tree or something. You run a lot of risk of exposing people and also not having good control of that technology. So I generally don't recommend that approach to it. I think in a house like I did, lots of portable HEPA filter units may be the best solution. Yeah.
Mike Lubliner, Oak Ridge National Laboratory. Bill, I want to thank you for your presentation today and all your leadership at ASHRAE. Having been on the 62.2 for doing my penance for, I think, almost 20 years with others in the room, I wanted to talk a little bit about, get your perspective on the residential side. And you hit home with the Swiss cheese, and I think this big hole in the Swiss cheese for residential has been, as you talked about, maintenance and getting people to operate systems. And I've been doing research in the Northwest for 35 years on build tight, ventilate right. And the biggest hole in the Swiss cheese is the occupant education and the maintenance and operation. And I really think that this is the future. This is the biggest challenge. And I see the value proposition of smarter ventilation controls that maybe take the occupants out of the equation. Anyway, so I'd love to get your perspective on that. Where we're going to go.
Well, sure. I mean, maintenance is always a problem, but in homes, especially, I mean, there's nobody looking after it, so you could have the same filters in an air handling unit for 5 years. I think mechanical ventilation too is important because there's so many naturally ventilated homes. Something I was discussing earlier in the weekend with someone was HVAC as a service. I think that the answer for a lot of people would be if I had a company that was making sure that my systems were working, delivering good energy efficiency, good air quality. That would be the best way to do it. We've seen that in lots of settings. Don't ask someone to do something important that's not really their mission. The homeowner just wants to live in their house and have things work.
Thank you very much.
Yeah.
Hi, Chris Benedict. I'm an architect in New York. Very early on in the pandemic, I had some communication with you, and we talked a little bit about putting UVC in ductwork. And you had said that there was still not a lot of knowledge about the length of the UVC and the CFMs of the air going past it, and I was curious whether any more work has been done on that.
Yeah, well, it mostly comes down to having software for design that you can have a ductwork configuration and put the parameters in and determine what the dose is. And I may be a little behind on what the manufacturers have now, but for a long time we've had the ability to predict the performance of UV installed in an air handling unit, which is often the best place to do it. I'm not sure what's being done now for distributed UVC in ductwork, but I think if you've got a central air handling unit, it makes more sense to just put it there instead of in individual ducts, unless you only want to protect one space or one part of a building.
This was specifically for ERVs.
Yeah, like
Yeah.
that's a problem that could be addressed pretty simply. We have the modeling capability to do it. I just don't know that the manufacturers are doing that who sell ERVs or those who make UV
Well, that's
products.
why I wanted to put it in the duct instead.
Yeah.
Yeah. So are you saying we're relying on manufacturers to kind of give us this information?
Let me say one other thing. If you've got an ERV and it's once through, why would you put UV in it? You're disinfecting the outdoor air, or you're
If you have an
disinfecting the air
ERV
that
that's
you're going to
connected
exhaust.
to multiple rooms.
Yeah, but it's still outdoor air going to multiple rooms, and it's outdoor air coming back from multiple rooms. So the only thing you have to worry about is the bypass.
Yeah, you have air moving through a core.
Yeah.
There's a possibility of some
Yeah.
crosstalk at the core.
Yeah, so
before-
maybe all you need is something to decontaminate the core. I'm kind of engineering on my feet here. Maybe it's not the air you need to worry about. Maybe if you're doing surface disinfection, that would be enough. But you know, that's something that could easily be engineered if someone decided they wanted to do it.
Paul Grahovac with Prosoco. I was hoping you could address the relationship between building envelope air tightness and facilitation of the engineering controls you've been discussing.
Yeah, well, you know, I pointed out, not specifically envelope, but some cases where not taking care of controlling where air goes in the building can contribute to infection transmission. I think that's going to be true in a lot of buildings. Once you've decided the direction you want the air to go in, then you need to control it to do that, and controlling unintended airflows through the envelope is an important part of doing that. So I think it's an issue that needs to be looked at. I don't know if that's right at the top of my list, but I think it's certainly something that shouldn't be ignored.
Edward from PNNL. I have a question about the Wells-Riley model.
The Corsi-Rosenthal box?
No, the...
Wells-Riley, okay. I said,
Yeah. So with that equation, it does not have a variable for how close people are to each other, proximity within a room?
As I presented it, no, it doesn't, and it kind of assumes steady state conditions and average concentration in the space. That's the way it was originally proposed. So that's right. It doesn't give you the effective proximity to the infector, but there are a lot of more recent tweaks on that model. It's been done as a stochastic model. It's been done to take time averaging of variables into effect. And I know there are some who are working on models of infection risk that do take distance into consideration. But the problem is always, which one of you is infected? Would the 3 people in this room who have COVID and are contagious, please raise their hands. So it's an important limitation of the model. It's one reason that I say don't rely on those estimates is absolutely correct. Is there are, so see, right now you kind of have to partition it. I know that from the point of view of the ambient air I'm breathing in here, I can put a handle on a wrist. The other part, maybe I should be wearing a mask and maybe I should be distancing if there's a lot of perceived risk.
Okay.
Next question. Last question.
Thanks. I'm Jonathan Bean from the University of Arizona, and I'm familiar with your work because I was asked to interpret some of it to make recommendations and to help assure my fellow faculty members who are very concerned that they were going to get sick returning into buildings that had been sealed up and sealed shut. Many buildings on the campus had operable windows and they were closed by the facilities plant because we have a central refrigeration plant. Figured they did some quick math and figured, well, if everybody opens the windows, it's going to get really hot in all of our buildings because it won't be able to keep up. So my question specifically is looking at the position paper on carbon dioxide and the recommendation sort of embedded in some of the pandemic guidance for this equivalent outdoor air calculator. when you seal a building up and you introduce equivalent outdoor air to some of the equations, the consequence is that you get very high carbon dioxide concentrations over time. Like if a classroom is continuously occupied, from the beginning of the day to the end of the day, you end up with very, very high carbon dioxide concentrations. That, I guess what's the guidance on that, or what's the thought on that? That's a consequence. The air inside is still safe because safer because it's been filtered. But I have colleagues who are very interested in the relationship between productivity, alertness, and carbon dioxide levels. How does all of this intersect in your thinking?
Well, if you read through the core recommendations, the first one on ventilation says have at least the outdoor air required by code. So there was never a recommendation or a suggestion that you could shut off the outdoor air to a building and put in enough HEPA filters to take care of body odor and VOCs and everything else. So the key insight here is that outdoor air is specific to whatever it is that we're trying to control. This system has one clean air delivery rate relative to infectious particles, and it has another one relative to building-generated contaminants, because I don't think the UV or the Crocier-Rosenthal boxes are doing much about VOCs or body odor. So that's the issue, is that we have to generalize concept. Was I pointing at you, Joe?
Thanks.
Sorry, it's an accident.
Last question.
So, Bill, help us out with a typical classroom, because the Harvard School of Public Health stuff has really been worrying me in terms of how it's being interpreted. So we know that a 10-foot ceiling room, 1 CFM per square foot is 6 air changes an hour, right? So there's your 6 air changes an hour.
Yeah.
I got 20 people in the room. It's 900 square feet, typical classroom. 900 CFM of outdoor air is 45 per occupant, which seems like a lot, way above 62.
Yeah.
So do you think that's the right solution if it becomes interpreted as equivalent and you do ASHRAE 62 for outdoor air and you make up the rest of it with filtration?
Yeah, basically, there are a lot of sciencey people who just wanted to talk about ventilation early in the pandemic. I kept saying that, that dog's not going to hunt. But with the recommendations on air changes, in my own mind, I could just convert them back into flow rate per student. I worked with the Friends School in State College, and we went through a process like here. They had an ERV, they checked it, we made sure they were doing what they were supposed to. They were meeting 62.1 for classrooms, and we wanted to get them at least to the WHO 10 liters per second per person, so 21 CFM equivalent, by putting in portable air cleaners. So we selected air cleaners for all the rooms, and now the latest phase is Bill Palmer and I are talking with them about putting upper room UV in their common room in a library, which they see as their higher risk spaces where people are doing activities that could be generating a lot of aerosol, and they're there for extended periods of time.
So are you comfortable with that 6 ACH equivalent for schools?
Well, that's because the classroom is kind of a standard.
That's why I'm asking.
Standard item. So yeah, if the 6 air changes per hour in a typical, say, 1,000 square foot classroom translates back into a ventilation rate that I'm comfortable with, then I'm not going to argue with people all day that they shouldn't be using the air change rates. And 6 air changes per hour in typical classrooms, probably beyond 10 liters per second per person. But I wouldn't go beyond the old 30 CFM or 14 liter per second per person limit. I think that's really excessive, unless you can put in something like UV that's really going to jack it up without costing a lot of energy
Thank
use.
you. Thank you. Bill, fabulous. Thank you. Thank you. Thank you. Okay, lunch, everybody back here at 10 after the hour. Go to the tent outside.